We are going to get started here. I'm sure my peeps will let me know if there's a problem with regard to video or audio streaming. So first, thanks so much for being here. We're going to focus today on how to read an ankle MRI for regenerative medicine. This is really just one part of a multi-part series. As you know, I've been going through these, how to read a lumbar MRI, how to read a shoulder, knee, etc. And the real goal is trying to get physicians to focus on how to do some of these things themselves so that they can change the lives of their patients using precise regenerative medicine, which is what interventional orthopedics is all about. So we're going to start with an unabashed nonprofit commercial. This is a presentation through Interventional Orthopedics Foundation. What is that? It's a 501c3 focused on interventional orthopedics. And we're really looking to create a new medical specialty that bridges the gap between conservative orthopedic care and invasive surgeries. Really analogous to what happened in interventional cardiology, right? In the mid-1980s, when I was in medical school, what we saw was pretty much every 50-some-year-old guy who got a coronary artery bypass surgery. Eventually, all of that was replaced, or the vast majority of it, via percutaneous procedures in interventional cardiology. So we really see the same thing happening in orthopedics. And we need your help to build and shape this medical specialty. We need your help as instructors for IOF, if you're so inclined, and you've got that skill level. We need your help with serving on committees at IOF and determining what it is we're going to teach, how it is we're going to teach it, etc. So see interventionalorthopedics.org for more information. And if you join IOF, there are discounts on courses, obviously live webcasts like this one, complimentary listing in the directory of members, opportunity to serve on committees, and very important, participation in the patient registry database. And that's really the largest registry of its type right now. There's nothing even out there that's a close second. We're tracking, for instance, 10,000 stem cell treated patients going back to 2005, so for 12 years. And the core skills program is set up with level 1, 2, and 3. So in level 1, today we're going to be focusing on ankle foot. And then in April, this is coming up in just a couple weeks here, we'll have a level 1 ankle foot hand wrist course. And then there's a level 2 course, ankle foot, which will be in May. And then obviously there's a level 3 course that will be at a later date. So the level 2 course is basically what you see here. All of these different areas will be covered. And as you can see, there's quite a bit to go over. So this is a very chock-full 2-day course to get all this stuff in, and a lot of common things that you would see in your practice, right? You see a lot of plantar fascia problems. You see a lot of ankle osteoarthritis. These patients, even if you don't attract them, will walk through the door when they come in for their knees and hips and shoulders. Same thing with CMC arthritis, which is a big deal in a lot of patients. It's actually one of the most common types of osteoarthritis out there. And then obviously a level 2 course focusing on tendons, on nerve blocks, focusing on ligaments as well. So really kind of a 1-2 punch of getting all the foot and ankle stuff done, including a bunch of hand wrist stuff as well. So Colorado in the spring is very beautiful, so really consider coming out. So why give this lecture? I see a lot of practicing physicians who really rely on the MRI report, and they're missing many findings that could help guide their therapy. And right now, regrettably, we tend to have radiologists reading for surgery and for conservative care, but not a lot for interventional orthopedics. There's not a lot of reading going on in the middle there, and that's a problem because as I'll show you, even the way we describe some of these injuries don't fit what we know about how regenerative medicine works. So you need to be reading all of your own films. What does that look like? I use a radiologist, obviously, for confirmation or to rule out bad things. I do generally review the radiology report, but when it comes to everything I'm focused on for Regen Med, I read all my own films. I don't rely on what the radiologist says. Not because I don't trust the radiologist, just because we're looking for different things. So my focus with this, let me go backwards here for a second. So my focus with this talk is not to train you to be a radiologist. I'm going to skip over some of the pathology in ankle, for instance, that a radiologist might get all excited about, but because it's rare and it's not something that's generally treated with regenerative medicine at this point. I'm going to focus on the things that I know regenerative medicine works well for. So how do you get better at reading your own MRIs? Well, obviously it's reading patient MRIs. It's reading an MRI and looking at the report. And if you do this long enough, you're actually going to get better than the radiologist in finding the things that you're interested in seeing to determine whether or not someone's a candidate. And you'll also have the ability that a radiologist doesn't, the ability to correlate MRI findings with an examination. So one of the first things you want to do is get started with a standard DICOM viewer. And this is the one I use. I don't have any relationship to this company at all. I just think they make a great product. We have used a lot of different standard DICOM viewers. And what I mean by that is that, you know, you open up this CD and it drives you a little crazy. You're looking at probably at least 10 to 20 common programs that you have to master. And it's one of the reasons why I think doctors don't like to read the MRI in front of a patient, because they're afraid to look like an idiot. They don't know where this is, where that is. If you use a standard DICOM viewer like Radiant or something else, you can master that viewer and not use the viewer that comes on the CD. And it really makes you look like a superstar in front of the patient. You know where everything is, you know how to measure, you know where all the little parts and pieces are. And it really helps to get that patient buy-in that you know what you're talking about. So let's just go over some very simple MRI basics. Obviously, we've got the sagittal, coronal, and axial plane. So we have all three of those planes. And that's what they look like on an MRI view. And recognize that in a T2 image, we have muscle is dark, fat is dark, water is bright, and bone is dark. On a proton density or T1 image, it looks a little different. And we use these different images in order to be able to identify what these things are. So let's start with some anatomy, and we'll go simple and we'll get a little bit more complex. Obviously, we have the big joint, which is the tibio-talar joint up in here. So the main ankle joint. We've got the subtalar joint in here. We've got a tib-fib joint over here. So we have three main joints in just the ankle. Some people would add in the talonavicular joint right here as well. So that's another option to add in. And we've also got the sinus tarsi right here, which we're going to talk about. Now, if we look at ligaments, you know, most people, I think, have heard of the ATF, the anterior talofibular ligament, the PTF, the posterior talofibular, the CF, the calcaneofibular ligament. Fewer people seem to be familiar with the medial ligament, which is the deltoid one. And I will tell you that the deltoid one is a very important ligament. We see a lot of issues with it, but it seems to sail over the head of a lot of providers. So I would really encourage you as we go through this to learn how to look at the deltoid ligament, the medial side ligaments, as well as the lateral side ligaments. So sinus tarsi. The sinus tarsi is really interesting because if you're looking at ligament stability, it's a player. But few of us have been taught to look at it or care about it. So as you can see here, there are a load of different ligaments. These are just two different diagrams here within the sinus tarsi. And we can see that. And obviously, if there are ligaments in there, those ligaments can get stretched and lax. So we should likely be treating them as well. So just make sure that you understand that obviously we're used to looking at the medial and lateral ligaments, but we have this central ligaments that are this very complex configuration that are probably equally as important but often ignored. So we have the lateral and medial side here with regard to tendons. If we look at the lateral side, we've got the peroneal tendons, and I'll talk to you about those in a little bit. We've obviously got the medial side tendons as well. And then we've got anterior tendons. So those are the three different areas. Now, for the purposes of this talk, I'm going to talk about what's most commonly seen. And what's most commonly seen here are issues with the medial and lateral tendons. So that's where I'll focus for the purposes of this lecture, because we could spend an entire lecture just on tendons. So let's talk a little bit about bone. Bone is the first thing you see. It's most of what you see. And again, oftentimes it's ignored by physicians because they're looking at cartilage, but bone is equally as important. So one of the things to recognize, and I'll tell you in any of these lectures that I do on the musculoskeletal system, is looking at what's called a BML, bone marrow lesion, or bone marrow edema is a big deal. So what does this mean? This is a fluid-filled and swollen area of the bone that can have microfractures. And literally, it's these small little fractures in the bone, and it's believed that that's what we're seeing here when we see these bright spots on T2 or these dark spots on T1 or proton density. And treatment with orthobiologics may be appropriate. We're treating many more BMLs and BMEs than we used to. And I think it's something to consider as a treatment target. Obviously, that's something that requires a little bit more finesse than injecting a joint. But in the ankle, what we tend to see, more similar to the hip, is that these BMLs and BMEs quickly turn into cysts. And obviously, if left untreated, you can get this whole area of the talar dome collapsing. So just recognize that if you see a BML or BME, it's probably a future cyst, and that future cyst is probably not a good thing for the overall health of that ankle joint. Much more similar to the hip, where that's very common, than the knee, where it happens but is less common. So this is an example here of a tailless BML treatment that we performed. This is a 15 gauge on control trocar dialed in to the tailless. And we have a level 3 course available that looks at treating bone. So something to really consider. So for osteoarthritis, we're going to switch gears now and talk a little bit about the joint. Obviously, with regard to cartilage loss and regenerative medicine, no orthobiologics technology to date has shown really widespread cartilage regeneration in a severely degenerated joint. And anyone that tells you any differently doesn't know what they're talking about. I've been doing this longer than anyone else, 12 years. I've injected more joints, I think, than anyone probably on earth. And we don't see this kind of severe, in this case, subtalar OA with lateral displacement of the calcaneus, likely due to a torn up deltoid ligament over here. We don't see that kind of joint regenerate using regenerative medicine. Now, we've seen small lesions fill in, and we've also seen patients like this respond without evidence of regeneration. Sometimes their bone marrow lesions will regress. And there's lots of different chondral lesion grading. I would say that I'm really more comfortable with a simple score like this because I very much doubt that we're going to see this type of complex grading fit very well into the regenerative medicine pantheon. Already, for instance, we're seeing in knee that even this outer bridge classification or the Kellgren-Lawrence classification, which is similar, doesn't really correlate to outcome, whereas in hips it may, and in ankles it may. So, so here we have a focal chondral lesion, and something to really be focused on in the tibio-talar joint is that we will see these small BMLs, and you can see here this bright spot in the bone. And that bright spot in the bone is frequently adjacent to a bright spot in the cartilage. So you see here we have gray cartilage out here in the middle part of the joint, and then all of a sudden this area at the corner of the joint gets a bit brighter. So one of the things you can really help yourself with in reading this tibio-talar joint MRI is looking for the bright spot in the BML and then trying to look at what's going on in the cartilage. And even more so in the knee, you tend to see these nice correlations. In addition, in the tibio-talar joint, you tend to see these corner lesions. So they tend to accumulate in the corners quite a bit. And you know, here, something to really be cognizant of or to realize is that oftentimes we'll again see a corner lesion like this, where you can see a very nice bone lesion right there. This is a dark lesion on a proton density or T1. And what we see here on the opposite side is a lax calcaneofibular ligament. So again, instability on this side in the ankle related to a lesion on that side. So something to really consider when you're treating these patients is obviously you're going to perform some sort of tibio-talar regenerative medicine injection here, but you're also going to treat the opposite side ligament. Now, there are stress ultrasound procedures that you can do to really sort this type of issue out, but at the same time, you can also, as I'll show you, look at the MRI to give you a sense of whether or not that ligament's involved. So here's another good example and something to really consider. Looking at this coronal MRI image here, we can see off to the far left that the calcaneus kind of lines up with the talus, and that kind of lines up with the tibia. So we can see that the forces coming from the ground here are going to go up very nicely up into the leg. However, look at this patient's MRI in the right two images, and we see something different. We see that the calcaneus is flipped out that way, and what's over here, the deltoid ligament complex is right there. So by definition, that deltoid ligament complex has to be stretched. And then on the opposite side of the subtalar joint, what do we see? We see a large bone marrow lesion right there with some early cysts. So again, laxity over here, leading to, in this case, a change of symmetry, leading to impingement on the opposite side. So treating this person's lesion on the lateral side of the ankle, which is over here, is not enough. You've also got to treat that deltoid ligament if you want to make any long-term progress. So here we have severe ankle OA associated with bony changes. And again, as I've said, the ankle is similar to the hip, where severe OA is associated with cystic changes and flattening of the talar dome. Very similar to flattening of the hip. So we can see here a BML, see here a BML. We can see complete loss of cartilage in this area. Over here we can see some gray cartilage, but the signal is not homogeneous, which is something else we're looking for. We can see that the signal on this side is kind of mottled. And if we look at the overall shape of the talar dome, it's kind of a mess. We got a bump out here, we got a bump out there. It seems to be good there, and then this part is expanded here. So we've lost the normal ice cream cone shape of the tibial dome. I'm sorry, the talar dome. Apologize. So this is more subtalar OA and TTOA. So you see, again, no cartilage up here. You can see the joint fluid coming out the back of the joint here. And then again, we have the tibiotalar joint with the joint fluid coming out the back right there. Now we have still some gray cartilage present in the subtalar joint, but up in here, we have no cartilage. And we obviously have a lot of bone marrow lesion here and bone marrow lesion there as well, with a cyst located here. So if we look at treating osteoarthritis by focusing on the joints, intra-articular joint treatments are the coming up level 1 course in ankle foot. That's in April, and we'll also cover a slew of different hand injections at that time as well. Okay, so let's look at the ligaments now. So for the purposes of interventional orthopedics, we have a different metric that we're looking at. Hold on, if you could, I'm going to hold on a quick second. I just need to deal with some local noise issues here. We're having some noise issues on our side, so let me just break for just a second. Okay, so dealt with our local noise issues there, but basically, and this is why I think the radiology reading system probably needs to be changed for regenerative medicine, because as far as regenerative medicine is concerned, I don't really care if it's a grade 1, 2, or 3. All I care about, based on what I've seen in 12 years of treating torn ligaments with stem cells, PRP, and all sorts of other things, is the following. Do I have a partial tendon or ligament tear, in which case that's more of a PRP type patient? Do I have a complete non-retracted tendon or ligament tear, which is where there's still fibers that are attached to each other, in which case it's more of a same-day stem cell type treatment? Or do I have a complete retracted tendon or ligament tear like a rubber band, in which case, if there's a lot of gap there, it's highly unlikely that a stem cell injection procedure is going to help. So I would use, for most scenarios, 1 centimeter as my gap here, and if it's smaller than 1 centimeter, that's something I can generally treat. If it's bigger than 1 centimeter, that's not something I'm probably going to be able to treat using this type of technology. So let's look at some lateral ankle ligaments. And coronal is really the best way to image the calcaneofibular ligament. So the calcaneofibular ligament we can see well on coronal, but we're also going to need to come to the axial to see other ones. So if we look at calcaneofibular ligament here, we've got the fibula here, right? We've got the calcaneus here. So we've got the calcaneofibular down here on a coronal. If we look at the PTF ligament, we've got the talus here, we've got the fibula here, and the posterior talar fibular ligament right there. Now we can also see these on the axial images, and we have our first axial image over here, and we can see this posterior talar fibular ligament very nicely here, and we can see kind of a shredded anterior talar fibular ligament on the axial right there. So you need to use basically a combination of the coronal and the axial to see all the ligaments as well as you can. Now let's look at the high ankle ligaments, and these are best viewed on axial. Generally these tend to be ignored. A lot of the sports medicine physicians know about these and treat these, but many times they get ignored. So these are above those three ligaments I told you, and they go, tib-fib, and you can see here we've got anterior right there, and we've got posterior right there. Now there's a retinaculum in here that you're not going to see. This is our fibula, and this is our tibia. And you notice that obviously, if we just look at signal here, this should be dark. So basically, the one I'm looking at here should be a dark color, kind of like this right here. And we're seeing a light color, and that light color is throughout the ligament. So that's going to be more of a complete non-retracted tear. Now here, we're seeing dark in this ligament other than this portion right here, which is right where it attaches to bone. And again, that goes through, that signal change goes through and through. So I'm going to call that a complete non-retracted. So both of those would be really great ligaments to try with likely bone marrow concentrate, but you might also consider trying PRP to see if they might resolve, because ligaments, again, tend to be a little bit easier to treat than you might with some other types of tissues like cartilage. So here's a good example of something that I wouldn't use PRP on that would definitely go straight to bone marrow concentrate. This is a complete non-retracted calcaneofibular ligament, and you can see here that this whole portion of the ligament is really amorphous and gray, and it looks disorganized. You don't see discrete bands there. So that's something where I'm going to start with bone marrow concentrate, and I'm not even going to think about using PRP on something like that. So let's look at the PTF here. So if we look at actually this is a PTF where we can see we've got this portion of the PTF, which is nice and rich and dark, but we've got this portion of the PTF, which is bright. So we're going to call that a partial PTF injury. And this is actually a pre and post PTF ligament tear after the injection of culture expanded MSCs, one of our very early cases. But it's a good example of a problem ligament, right? You can see automatically that this ligament should come across like that. So you have void here that's being filled by the ankle effusion. So we know that we have a partial retracted tear. And we also know there's a problem because we see a V sign here, right? That the ligament is bent. And we know that the ligament should go straight across and tight. Now, if you look at the right one here, you can see that most of that reconstituted after the injection of culture expanded MSCs, when we were still doing that here in the US, and before that got moved to a site in Grand Cayman that's licensed. So this is more of a high ankle ligament injury, and you can see here that you do have a posterior ligament that maybe has some bright areas in it, but it's holding together, but you don't really see this one in the same way. And now let's look at the medial ankle ligaments, superficial and deep. So there's a lot going on in the medial ankle. You've got actually a anterior component of the deltoid, a posterior component of the deltoid, and then you've got, those are deep, and then you've got an anterior, middle, and posterior superficial ligament as well. So if we look at the deltoid on the medial side here, you can see this posterior tibio-talar ligament very, very clearly right here, and it is triangle shaped. So that's your deltoid ligament there. In addition, you can see little bits of the flexor digitoris, the digitorum longus, and the peroneal tendon there. Now this is the spring ligament which is a very, very important component of all of this. We've got the ATTL, which is that deep component, the anterior portion of the deltoid ligament deep. Then we've got the tibial sprain ligament, or the TSL, coming out this way. And then this is actually the flexor retinaculum, and this is the posterior tibialis tendon. So again, gives you a sense of all the different structures here. Now the sprain ligament is super important, right? Because we've got really three different things holding up that arch. We've got our plantar fascia way down here. Then we've got a long plantar ligament down here. And then we've got the spring ligament there. So all three of those are holding up the arch. So if you have someone that's literally lost the spring in their step and or is getting a flat arch, again, all of these can be injection targets. So this is a deltoid ligament sprain. You can see here, probably best on this image right here, that instead of being nice and dark like the other one, we see a complete change in signal. So this would be a complete non-retracted. Again, not a surgical case in my book, more a bone marrow concentrate case. So now let's go over some ankle tendons. So sagittal is usually the easiest way to see and follow these tendons. So that's really how you want to do this. And you can see here that we see a tendon coming right around the fibula. And recognize that there are retinacula around all of these tendons. So there are pieces of duct tape, if you will, that traverse across and hold them in place. So a snapping tendon may actually need the retinacula tightened down via injection. And if you want to look on the lateral side, we see two major tendons. We see brevis to bone and longus. So literally, if you look at the fibula here, the brevis is going to be the one that's hugging the fibula. So that's how you tell it apart from the longus. So if you see them together on ultrasound or an MRI, the one that's to bone is the brevis. And so this is an example of an intersubstance tear with hypertrophy. So you can see here we've got the peroneus longus tendon right there, peroneus longus tendon on the other part of it right there. And then we have this split tear or intersubstance increased signal right there. In addition, the tendon is generally bigger, so it's hypertrophied. This is a complete non-retracted to partial tear of the peroneus brevis. So we can see here that we've got the longus back here, and then the brevis to bone right up front there. But as you can see, in parts of this down in here, the entire tendon has high signal. So if it's still attached or there's still fibers there, this is more of a bone marrow concentrate injection case in my opinion. And recognize that the peroneals on the outside can be impacted by ankle stability. So if you see someone with a peroneus brevis split tear, for instance, then that's something that you want to look at that ankle and stabilize that ankle before you really consider treating that brevis or treat them at the same time. I see a lot of these patients getting surgery, and I'm still scratching my head because most of them after surgery are miserable. They never really quite go back to what they were doing before. So I'm scratching my head as to why they're getting the surgery in the first place, and they're out for very long periods of time. And most of the time, the surgeon has not looked at small amounts of instability within the ankle. It just goes right over their head. So here's an example. Does this peroneal tendon need surgery? This is actually a patient of mine who regrettably got the surgery, and she was miserable. She was much, much worse after this surgery. So look at this tendon here. So let's first identify it, right? We got the brevis over here. We got the longus right there. So it's the longus. And we see in this circle some changes in signal within the tendon, but it's not totally torn. You might call this complete in that, it's not completely dark. So if we look at it from here to there, there's a change in signal, and there's obviously a little torn piece there that's slightly retracted. But if we look all the way down to its insertion, we're not seeing any type of complete tear. Again, complete change in signal here. So this is more of a bone marrow concentrate injection case in my opinion. I don't think this patient has any business getting surgery, which is probably going to piss off a lot of the surgeons, but I don't think this person in this day and age of PRP and bone marrow concentrate should be walking in and getting surgery at all. I think this needs to be treated via a highly concentrated bone marrow stem cell injection precisely placed in that tendon. And obviously, if that fails, they might consider surgery. But to me, this is an 80% likelihood of success case with much less downtime and much less morbidity than surgery. So if we focus on the medial ankle tendons and go medial to lateral, we've got the tibialis posterior here. We've got the FDL there. Then we've got the posterior tibial artery. And then we've got the tibial nerve. So recognize that that's how it goes. So here we see a split tear of the tibialis posterior tendon, and we can see some high signal in here, so you can call it a split tear. There's also some high signal here at the attachment. So again, in general, not a surgical case in my opinion. Achilles tendinopathy. Here we see just an Achilles tendon that really should be about this thick, that's gotten much wider here at this point. A great case for platelet-rich plasma injection. Here we have an intersubstance Achilles tear, where we can see that there's just this thickening and high signal right in here, indicating a problem within the tendon. Again, a great PRP case. And then here we've got a complete retracted tear, and regrettably, it's unlikely that a bone marrow concentrate injection is going to fix this. It's certainly worth a try, and if you were going to try it, you might consider paralyzing the gastrocsoleus complex up here with some myoblock or some Botox to bring these two pieces together. I mean, they are reasonably approximated, so you might also try to approximate them with a boot. But again, when you get into stuff that has significant retraction, you're talking more surgical, at least until someone invents the right device to treat this percutaneously. So this is more level 2 ankle foot stuff that we're talking about, which is a course, again, that we're holding in May. Okay, so now let's do some MRI reads. And for those people who probably got the time translation wrong and they're just logging on now, this will be available via recording, so you can watch it at your leisure. So I'm going to start these videos here, and that way you can have to do this just to be able to keep the patient's name out of it. So I'm going to let this video run by itself, and I'm going to bump up my sound here just to make sure you can hear it all. And you're not going to see me for a few minutes here, and you're probably going to see this thing jumping all over the place. So just recognize that that's not technical difficulties as much as it is just trying to make this so you can hear everything appropriately. And I'll start this video, which will run a little bit, and go over some actual live MRI reads. Okay, so the second MRI read is really a horse of a different color. This is much more severe osteoarthritis. First thing I want you to look at here is on the coronal view, because there's some interesting things going on. Basically, we have collapse of the talus medially, and an ankle that's really no longer aligned. So if we draw some lines of force, we've got force coming down this way from the top, and then we go this way, and then we go that way. So basically, not a healthy ankle. We're going to have impingement in here, which we can see evidence of. Let me get rid of this little thing there. Which we can see evidence of in this corner, where we have the fibula on the lateral side, meaning we see a BML here. And if we look at the sagittal, we can see on the, so we're going to move that over there. This is the slice I'm looking at. So we're now on the medial side, and we can see the tibialis posterior tendon, which has quite a bit of swelling, which we would imagine it would, simply because of the stress it's going to be under because of this whole medial collapse. And we're also seeing, again, quite a bit of bone marrow lesion in the subtalar joint with cystic changes. And recognize that we have two different tendons on this side. We've got tibialis posterior and FDL. FDL is going to be the second one you see. And then we've got the nerve artery vein complex back here, tibial nerve. And we can see here that the TT joint really has severe arthritis with no chondral surface at all to speak of. She's got a little bit of cartilage left right there in the weight-bearing area in the middle. Now, she's actually had at this point at least 2 culture expanded MSC treatment, so that could be where that came from, because it's an unusual spot. That's the weight-bearing area, and you wouldn't expect that to even be there. But it's also one of the probably lower load weight-bearing areas because of this arrangement here. And we also see a small beak osteophyte in the front of the TT joint. We see a subtalar effusion back here, which is pretty significant. And we see this is the flexor digitorum longus coming down this way, and a tenosynovitis there. Obviously, in front, which is not the purpose of this lecture, we're seeing multiple joints being impacted by this ankle. She also has her pain. This was placed here for her pain more medially. And shortly after this, we hydrodissected out the tibial nerve to try to help her. And something else that you can see on this lateral here, as we move laterally on the sagittal, is that the fibula is moved posteriorly because of this arrangement. Normally the fibula would be about right here. So something interesting to note. We can also see here that the Peroneus probably longus is torn. You can see that it's probably torn down here, and you get this circuitous course. And then in the brevis, we can see, Peroneus brevis, we can see some change in signal here. So lots going on in this ankle that has severe issues. Now, if we take a look at ligaments here, we'll try to cue those up because they're going to be difficult to even see in this patient. So this is PTF ligament here that you can see. The deltoid ligaments and the TT ligament right here, high signal in those. And hard to even make out some of the other ligaments because of the chronic issues in this ankle. Okay, this is our last MRI read, and it's going to throw a curveball. Okay, let's go with our first MRI read here. As you can see here, I have the T2 sagittal and the T2 axial up. Now, as we scroll through this T2 sagittal, you can certainly see right in here that we have quite a bright bone marrow lesion, or BML, or bone marrow edema right in here. And you can see brightness in the chondral surface right here. And in fact, in front of that, probably loss of cartilage. So certainly a cartilage lesion right there. And recognize that in MRI of the ankle, really following this bone marrow edema is important. In addition, if this is left as is, it's probably going to turn cystic over time. In fact, you can see possibly even a small cyst in the cartilage there. Then also notice there's quite a bit of edema here within the sinus tarsi, and what appears to be some possible disorganization of those ligaments with some cystic changes here where they attach. So that might be an old subtalar injury. And in fact, more to that point is that you have spurring in the back of the subtalar joint here with localized edema. That localized edema continues through multiple slices here. With regard to the Achilles tendon, let's look at that. The Achilles tendon right back here, you can see that there's some small change in signal within the Achilles tendon, so that might be a target to take a look at clinically. And what else here? We're not seeing the traditional beak-like osteophyte that you usually see anterior in the tibiotalar joint, so this may represent a newer injury to the tibiotalar joint. Now in the axial, you know, there's only a few things we're going to really look at on the axial. One is going to be for a high ankle ligament sprain, and you can see here that there's increased signal and cystic changes around back in here, the high ankle ligament. So this is the fibula, and these are the high ankle ligaments here and here. So probably a high ankle ligament sprain has occurred here. In addition, as I come further down, I'm going to be looking anteriorly here for the ATF ligament. And I really don't see the ATF ligament here. It looks like there's a complete tear right here of the anterior talofibular ligament. And we can see some of the posterior or talofibular ligament here, which will actually be better appreciated on the coronal image. So on the coronal image here, this is really going to be our ligament image, and it's also an image that tells us a lot here. As I said in the lecture, when you see these medial corner cartilage injuries, as we see right here, we see the brightness here, we see changes in the cartilage signal there. You really need to start looking at the lateral side for chronic laxity here causing compression there. So as we try to line this up here, we see the calcaneofibular or CF ligament, which does have changes in signal within it. This part looks more normal, this part looks more abnormal here. And then we also start to pick up the posterior talofibular ligament here, which looks highly abnormal signal, basically a complete through and through signal change or complete non-retracted tear. So we've seen an ATF with a complete retracted tear, a PTF with a complete non-retracted tear, and then portions of partial tear within the calcaneofibular ligament. Now, if we go and look at the deltoid ligament doesn't look great either. This is the PTT portion of the deltoid ligament, and you can see it's bright here on this T2. So that's an issue. So in general, we're seeing an ankle with multiple ligament injuries, an ankle with a tibiotalar, probably more acute type injury, a more chronic subtalar injury in that joint. Okay, and this is our last MRI read, and it's going to throw a curveball or two and demonstrate some interesting things. So first off here, we're starting on the sagittal. We can see that we have an effusion in the posterior part of the tibiotalar joint. We don't really see any BMLs in this more fat-sat type image. Really not much there, other there is some posterior spurring here to be noted. And also note that there's a loose body in the back of an effusion at the subtalar joint. And the subtalar joint actually looks a little bit more beat up here. We can see that we have a bone spur right here. We can see that we have some chondral changes. We can see we have some thickening of the cortex here. So subtalar joint of these two seems to have more osteoarthritis. And given that it also seems to have a small loose body, probably more going on there. Now we also see this a few loose bodies here, and this effusion, and as I've tracked it and gone back and forth, it actually seems to be coming from the talar-navicular joint here. So interesting. Now even more interesting, you're going to see a whole bunch of things here on this guy's coronal. The first thing you're going to notice is that there's an accessory ossicle here that has made its own joints. That's really at the bottom part of the fibula, more anteriorly. And so that's something. And that's kind of right where he has pain. There's some increased signal in that accessory ossicle. Seems like there's some chondral loss here, but we're not sure if there ever was cartilage there. And also notice the sinus tarsi here. This is a really great example in an otherwise active, healthy person, what some of these ligaments look like. So you can see this ligament going in this direction, and the sinus tarsi, another one there, another one here. All of them are not great. They've got high signal. These are more low signal. So quite a bit going on in the sinus tarsi. And as we look at the tibialis posterior tendon, it's got high signal. It's still there, mostly through and through, so that would be a complete high signal possible tear in the non-retracted in the tibialis posterior tendon. And then we can see again, we should see this dark ligament here, and we're not in the calcaneofibular ligament portion. So again, a candidate to look for tears. Now, most radiologists may not even call that. In fact, the radiologist that read this didn't call this. But I can tell you, from a regen med standpoint, and if you look at this under stress ultrasound, this is likely to be lax under stress ultrasound imaging. And if you don't know how to do stress ultrasound imaging, again, take these courses. Also look at the deltoid ligament. The PTT portion of the deltoid ligament, again, doesn't look dark like it should in this type of image. And the more superficial parts look like they've got changes in signal here of the deltoid ligament. So something else that's going to need to be looked at in this gentleman. And as we go over here, we can see something to note, and I always think this is so interesting how it all works out, is you can see here that this is his Achilles. Now, it doesn't have a very robust Achilles, but you know, I know this patient, he's a tall, very thin patient. That's probably why. But also follow the Achilles all the way down. You can see fibers that connect into the plantar fascia. So again, we have one fascial plane that's going all the way from the Achilles to the plantar fascia. These are not separate structures. There are definitely fibers there, and you can see those fibers under ultrasound at much higher magnification than this MRI will allow. So if we want to look at some tendons here, let's start with the lateral peroneal tendons. And we see some split tears here. So we see here, if we're going to identify these, brevis to bones. This is brevis. It's got high signal. Laterally as well, or sorry, more posteriorly, we can see a split tear or high signal intersubstance in the longus. So issues going on there. And then as we go to the other side, remember how all this is going to work. So we have here a tibialis posterior, which again has high signal intersubstance. And then we have FDL coming all the way down, which has some high signal down here. And then we have the nerve artery vein complex back here that we're seeing. So lots of different issues going on in this foot and ankle complex that may need to be treated, obviously, depending on exam. And again, MRI is no good without an exam. That's one of the ridiculous concepts, I think, of having the primary provider that reads these images not being involved in the actual health care, because an MRI is only helpful when it's combined with an exam. By itself, it can tell us some things, but sometimes it's fairly useless by itself. So it's an important concept here of everything we've looked at is going to need to be confirmed on stress ultrasound exam, whether or not the guy's tender there, et cetera, et cetera. So interesting read on this one. Okay, let me set this all back up here and we'll take some questions because I think we've gotten to the end here. So again, upcoming IOF foot and ankle hand wrist course level 1, but this is one heck of a level 1 course. There's a lot going on in this course. As you can see, many different elbow hand injections and ankle foot. Very, very common to see, obviously, patients with plantar fasciitis, MTP issues, tibio-talar, osteoarthritis, CMC osteoarthritis. I mean, these are all super common problems that we all see day in, day out. Even if you don't start with these patients and you don't attract them and you're just seeing someone for a knee problem, these other issues walk in all the time. So it should be a good course out here in Colorado in April. And obviously the level 2 for that, focusing just on ankle and foot because there's an awful lot to go over. We'll also cover many of these same structures that we've seen, ATF, CF, PTF, the high lateral ankle ligaments, the peroneals, the tibialis, the Achilles, how to do a tibial nerve block, how to inject many of these same tendons that we just talked about and saw, how to deal with a plantar plate tissue. I've had several plantar plate patients that we've been able to treat where they've had failed surgeries. Talonavicular, calcanocuboid, all of those things. So a lot going on in April and May, and I'd really encourage you to come out to these courses. So let's see if we can go to some questions to see if we have any right here. Also, I want to bring up, before I go to questions, before I forget, I think I had stated in one of those videos, it's kind of funny to sit and watch yourself give a video because I just played those videos to make sure I got the patient's name out of the field of view. Those are things I recorded over the weekend. And I erroneously called the PTF ligament the tibialis posterior tendon in one of those. So just to let you know, that was just doing too much that week. Let's see here. So John, what percentage of ankle injuries do you treat that are ATF plus CF injuries versus all others? Yeah, John, it's a great question. You know, I see, you know, it's really interesting. I think there's a tremendous amount of subclinical or not diagnosed ankle ligamentous issues. We see it all the time, and literally it goes over the heads of the surgeons because they look at it as a binary issue. If it's a complete retracted tear, great, I'm going to operate on that. If it's anything else, I'm not interested. It'll get better. But if you look at these under stress ultrasound, which we'll show you how to do during the course, because in this April course, there's actually a big hands-on component of doing diagnosis, and one of those things we'll cover is stress ultrasound. You'll see that there's an awful lot of ligamentous laxity out there that doesn't get diagnosed but needs to be treated, that eventually affects the knee and the hip, etc. Second question. So a very high percentage, John. When treating high ankle sprains, do you treat just superficially at the ligaments or deeper into the retinaculum? Yeah, not into necessarily retinaculum, but I think you're talking about the interosseous ligament. So yes, I try to get both in those ligament structures that we talked about, the tib fib, the anterior and posterior component, but also attempt to dive deep into the interosseous as well. And that's one of the real advantages, I think, of having both ultrasound and fluoro, right? Because you can dive in there very accurately under ultrasound, and then you can check under fluoro with a little bit of contrast to make sure you're getting intraosseous ligament before you then chase that with your biologic. So I think that answers that question. Guys, we have a question session now. If you'd like to, off on the right there, you'll see a space to ask questions. Please feel free to type any questions you have there. and I'm happy to take 5 or 10 minutes of questions if any have come up. In the meantime, while we're waiting for that to happen, let's see, what else can I tell you about foot and ankle? Something else you might want to consider, anyone else that's watching, is there's a fantastic book called Anatomy Trains, if you've never seen it, by Tom Mayer. It's really a game-changing book because it talks about how all these things are connected. I think in the last MRI read there, tried to show you how it's very clear that there are connecting fibers, for instance, between the Achilles and the plantar fascia. And it would make sense that there would be connecting fibers between those two areas. But it's not what we've been taught. And we've been taught to view these as separate areas, and they're really not. They're connected. And you can see it very clearly under ultrasound imaging, but you can even see it on that very nice, clear MRI that there were fibers that seem to connect those two. And that's really talked about quite a bit in anatomy trains. Okay, guys, well, it looks like we don't have too many more questions today. So I do want to let you know that this has been recorded. So if you arrived late, then you can get the recording from Nancy Ho. And she'll be sending out something to do that. And then, we got another question here. Oh, we got a slew of questions all of a sudden. Tony, when and how do you combine these biological or surgical intervention for severe issues such as loose bodies? Tony, it's a good example. So loose bodies are one of those scenarios where you may want to have the patient pursue an arthroscopic debridement before they consider doing a stem cell treatment. And normally I will place some time between those two. So basically about a week I think is optimal because you're still in that inflammatory healing phase. I don't know that I would give it too much more than a week because you want to be in that inflammatory healing phase from the surgery when you put a biologic in there. Let's see, Tom, can you do a stem cell regeneration procedure for the plantar fat pad? Yeah, Tom, that's an interesting question. We have done a fat graft there on at least one patient who did quite well. And so yes, so you're talking about plantar fat pad atrophy. That's something that you could certainly consider doing a fat graft on. Let's see. I think that's it on questions. Okay, guys. Well, Nancy will have this for you. Rolandus, wonderful to see you. Rolandus is working with us in Brussels, so so wonderful to see that it's probably very, very late in Brussels right now. So Rolandus, I'm glad you're up so late, and thank you for watching. So guys, thanks so much for watching, and have a great day.